everyone, and welcome to today's ADA webinar for mental health professionals featuring Dr. James H. Rich. My name is Lise Bram, and I am the Deputy Executive Director here at ADAA. As you might have heard, we are recording this session, and it will be available on demand as of Monday afternoon. Please feel free to introduce yourselves and let us know where you're joining us from. You can use the chat feature here on Zoom. If you have applied for CE credits for this webinar, you will receive an email from webinars@adaa.org this afternoon with a link and instructions for completing the credit requirements. You will have the opportunity to submit text questions through the Q&A feature, which you can see at the bottom of the Zoom screen. You may send in your questions at any time. We will collect these, and Dr. Rich will address them during our Q&A session at the end of the presentation, which will be about 20 or a quarter to 1. It is now my pleasure to introduce our presenter, Dr. James H. Rich. Dr. Rich is clinical professor at UCSF Department of Psychiatry and adjunct professor at the Stanford Department of Psychiatry. His current academic work consists of teaching psychiatry residents psychopharmacology and writing review articles largely related to personality and their relationship to anxiety and depression. Dr. Rich founded and received the Founders Award from the Association for Research in Personality Disorders. Thank you all for joining us. And now I'm going to stop sharing my screen and hand it over to Dr. Rich.
A pleasure to be here. Let me share my screen. Let's see here. There we go. It's a pleasure to be talking to the group today from ADAA. I have a long past history from them, and it's always been, I felt, an excellent organization, so I will enjoy talking to my colleagues today. Today I'm going to be talking about avoidant personality disorder, and the talk will be focused for clinicians rather than researchers. I have no conflicts of interest with this presentation. If we don't get to the question that you ask, this is my email, jhrich1@comcast.net. I'll try to get back to you if you need it. Now, I've listed some references here, but these will also be on the website. Basically, for the most part, so you don't have to write down references for those people who do. I know some do and some don't. Most of the things I refer to will be in one of these two articles, and this should be posted on the website. So you don't have to try to write them down and say what was on that one, what was on that slide. All right, so let me kind of take you through what we're up to today. Well, we can look at the definition and epidemiology of avoidant personality disorder. We're going to be doing this in adults. I'm not a child psychiatrist, so I don't want to stray from my area of expertise. We're going to look at why it's important, what damage it causes, and morbidity. The multiple challenges of diagnosis in the clinical settings, the breakdown of symptoms and approaches to each symptom, and then do a bit of a wrap-up. Now, DSM, the DSM definition of avoidant personality disorder goes back to a definition by Ted Milan, but basically it hasn't changed all that much from 3 to 3R to 4 to 4R to 5 to 5R. Basically, you've got a pervasive pattern of social inhibitions which can connect it to hypersensitivity, to feeling negatively evaluated. And it usually begins in early adulthood and is present in many areas of the patient's life. These areas can be occupational, friendship, intimate relations, social relations, situations involving personal risk. So avoidant personality disorder is one of those diagnoses which seems to have stood the test of time without a lot of change. Now, before we decide something's worth talking about or looking at, there's a question is it common? I mean, the two things we look at to be concerned about a diagnosis is how common is it and how severe is it? Avoidant personality disorder is common. I looked at a series of epidemiologic studies of patients in the community that took in a total of 65,000 roughly people. And when you average out the prevalence, it was 3.3%. So this means in the community, about 1 out of 30 people have this, which is a fair number of people. There was one study of women in Australia where the prevalence was 9.3%. I'm not sure what's going on there, but I mean, I just throw that in as, you know, some places it's possibly even higher. Now, that was, however, in the community. Like you just survey people in a city or a town. But in clinical populations, we know that we get distilled pathology, so it could be as much as 5 times higher. So I think it would not be unusual for us to get at least 1 out of 10 patients with significant avoidant personality traits or disorder. Now, a number of studies have done factor analytic analyses of the symptoms of avoidant personality disorder. And I'll tell you, when you look at these, they're kind of boring because a lot of studies, when you look at these things, somebody finds this, somebody finds that. You have to kind of figure it out. Avoidant personality disorder, all the studies are consistent. There's one factor. Okay. And this factor is characterized by feelings of social inadequacy, let's say social risks, being interpersonally inhibited, fearing rejection, and being fearful of taking the first social initiative. Now, I should say here, and I'll emphasize a little more, just because there's one factor does not mean that it's you're only treating one thing, within the fact that there are a number of themes which will break out for treatment. But factor analytically, we have one factor. And interestingly, the same factor is found in avoidant personality disorder and social anxiety disorder. These come out to be identical. What this tells us is that we may have a leg up on treating avoidant personality disorder since we have a lot of treatments for social anxiety disorder. And since they have the same factor, some of these treatments may be transferable. So, all right. So we talked about how much of it there is, which is a fair amount. The other thing that will make us interested in the disorder for treatment is how much damage it causes, the morbidity. Avoidant personality disorder has high levels of attachment anxiety, which interfere with the formation of relationships. So we get smaller social networks. There's decreased chance of marriage. There's lower socioeconomic status and lower employment. There's less education. There's lower income. And there's poorer self-rated health. Already you were saying there are problems here. One study showed a lifetime occurrence of non-suicidal self-injury of about 50%. This is something which you don't think about in avoidant personality disorder or traits, but apparently is present. So the decrease in global quality of life for avoidant personality disorder is as severe as other severe personality disorders, such as borderline, paranoid, and schizotypal. Now, due to the nature of this disorder, which is kind of has people being sort of recessive, it doesn't slap us in the face like something like borderline, but the morbidity is nonetheless very high. Okay, I repeated that. The morbidity is severe as borderline personality disorder. All right, so the question is, why don't we have frequent seminars on treatment of avoidant personality disorder? Why don't we have long courses at the American Psychiatric, American Psychological Association? And this is for a couple of reasons. One is the patients do not bring it forward. And so by the time it comes to us, they're usually presence of comorbid disorders, which is the focus of treatment. So people tend not to present as avoidant personality disorder. They tend to present as maybe major depression, substance abuse disorder, alcohol abuse disorder, or perhaps some other anxiety disorder. In less than 50% of the cases where avoidant personality disorder is present, is the focus of treatment. And I ran across this interesting finding, which is on social anxiety disorder, but I think relates. Between 1996 and 2016, psychotherapy for social phobia declined from 29% to 8%. So to some extent, this may be involving the decline of psychotherapy in general, but it also seems to indicate that for some reason, these avoidant personality traits are not getting the focus they might otherwise deserve. So this brings the question, why are these not being diagnosed or focused on? All right. Now, there's a lack of desire in the patient to bring this forward. As with many anxiety disorders, this behavior is often perceived as a character deficit by the patient. We see that, and I've seen this with panic disorder, you can definitely see it with avoidant personality disorder. It's not that people feel, oh, well, I've got a disorder, I need treatment. It's they feel like it's a defect in their personality. And that's not something that's should be a focus of treatment. When by the time it does present, there are comorbid disorders which are more prominent, which will attract our attention first. And as I mentioned, there's shame and minimization by the patient. So what aids can we have in the diagnosis? To borrow a phrase from a Conan Doyle Sherlock Holmes story, the dog that didn't bark. I mean, that may be showing my age. I don't know if people read Sherlock Holmes anymore. But basically, unexplained lack of relationships, unexplained failure to advance educationally, occupationally, or even failure to respond to treatment of the comorbid disorder should trigger our suspicion that there's something else going on, which could well be a personality disorder and could well be avoidant personality disorder. I mean, there's actually a very good series of reviews by different authors now, which indicate that personality pathology will affect the treatment of They used to call them axis 1 disorders. I think now they call them major syndrome disorders. The other thing is it's very necessary to create a level of rapport with the patient because these are sort of shameful symptoms to them. And you need to educate them on the fact that these are not uncommon, that perhaps 1 in 30 people have them, that it's not, it's not a rare, unusual event. Now, when I was putting this talk together, I thought, well, are there some scales which would be of use to clinicians? And I thought, well, I should find something for the clinician who doesn't have a lot of time and they don't want to spend a lot of money if they don't have to. Now, so psychologists are amazingly productive, and it seems like they churn out a new scale every five days. That's well validated. But I chose a couple that seem to be easily accessible and free, and which might be useful. The Liebowitz Social Anxiety Scale, again, there's a continuum on symptoms between social anxiety and avoidant personality disorder. That's common. Actually, I found it free on some place called the National Social Anxiety Center. I don't have any idea who they are, but they have a free Liebowitz Social Anxiety Scale. I also found a big 5-factor measure, which seemed to have been invented by MIT, which is free, and it's just, it's here. It's like big5test.com /test, which actually I took it myself and was very easy to use, and actually gave you all 5 factors, not just avoidant personality, which is very useful. Turned out that I'm obsessive and a bit compulsive, but well, that's not actually a big surprise here. I mean, beyond these 2, which I'm kind of putting forward as relatively easy to use and at no cost, they're structured interviews, there are all kinds of other interviews, so there are many of them, but I selected a couple to recommend as being somewhat easy and inexpensive. So now we're getting to the symptom structure. We got 1 factor, but there are a lot of symptoms that are different that might be the focus of treatment. There's a generally inhibited temperament. There's lack of motivation. There's fear of social contact. With avoidance, there's a pattern of reinforcement avoidance, which is extremely important. This is where someone faces a situation where, or so begins to get to a situation where they're scared of and they pull away. This creates a sense of relief and it's tremendously reinforcing. And after it's done a while, that can be a very powerful factor. There are also beliefs that can be challenged, behavior, and there is cognitive bias as a possibility as well. There's lack of social experience and network. There's shame. There's demoralization resulting in lack of motivation. Now, let's start here with inhibited temperament. Now, I often see patients, I'm a psychiatrist, so I treat by both medication and psychotherapy. And I will at times see someone who's depressed, who has an awful personality. And I will suggest a antidepressant like Prozac or something like that. And they'll ask me, say, this won't change my personality, will it? And I think, if only we could, if only we could. But we still can't change personality, but we may be able to do something with the inhibited temperament with medications. Now again, these are not brought forward spontaneously. you kind of have to probe and take the initiative to diagnose. But once you do, medication is a possibility here. The first line for this are the SSRIs and SNRIs. These are common antidepressants that are well tolerated with relatively few side effects. I mean, sometimes it seems like a quarter of the world is on these. There is some empirical evidence that they may be effective for these kind of anxiety symptoms. There are anti-anxiety agents. All the benzodiazepines and clonazepam have been shown to be effective, although weaker evidence for prazolam, which I don't recommend. Now, there are, whenever you talk about benzodiazepines, people get a little leery, which is understandable because there are potential risks. There is the risk of substance abuse. If you are not on a steady dose and have just taken it, it can affect motor coordination. Concentration can be a two-edged sword. If you're highly anxious and you get less anxious, the concentration may improve. But if you are not as anxious and you have this and you reduce and you add benzodiazepine, the concentration can get worse. And you have to recognize the difference between tolerance and dependence. If you have a patient on a regular dose of a benzodiazepine and you stop, suddenly they will feel a withdrawal effect. Well, so they get tolerant of it, but tolerance is where the body develops somewhat of a adjustment to it and you feel withdrawal, but under the care of a physician for specific symptoms, as opposed to dependence where the patient is just kind of doing this on their own hook. So basically, benzodiazepines are an option if there's no history of substance abuse and other factors are carefully taken into consideration. One of their advantages is the rapid onset. Beta blockers, such as propranolol, are basically useful for circumscribed social situations and less effective in more generalized situations, but some of our patients, they may be worth a try for certain situations, even for the avoidant personality patients, for public speaking, test taking. A wonderful advantage of the beta blockers is a lack of side effects. The cardiologists use this for high blood pressure and they start at 50 milligrams. Psychiatrists use 10, and it does not affect cognition. So the brain works just fine. So in that sense, it has a wonderful lack of side effects and can be used when people need to have complete use of their faculties. Some of the anticonvulsant medications have been repurposed. There's evidence for the use of pregabalin. This is something, so there's some solid research on that. An advantage is its lack of addictiveness. The disadvantage of it is the potential for sedation. Again, just another thing in the toolkit. Decycloserine, there is some evidence it may accelerate the speed of the exposure therapy. If you're using exposure therapy, may not necessarily change the endpoint, but there's probably some value in some cases to accelerating the speed of the treatment to some extent. Monoamine oxidase inhibitors. There is evidence of effectiveness, but problematic side effects. There's like a interaction with tyramine, which is commonly called the beer, wine, and cheese reaction. So you may probably want to work with a psychiatrist's experience with their use. If you get down there to this level, it's not a first choice, but it is a choice. And there is a patch now, which does get around the GI side effects, the beer, wine, and cheese. And the only side effect it has is that sometimes people get irritation around where the patch is. There are also so-called irreversible monoamine oxidase inhibitors, which do not cause the beer, wine, and cheese effect, but they don't appear to be effective for the anxiety symptoms we're treating. All right, so lack of motivation is another symptom. I mean, here you probably you have to treat the comorbid disorders if necessary. Major depression, substance abuse. I mean, I had a client who I thought described this situation very well, which was, I asked him why he didn't do something earlier that at the time seemed fairly obvious. And he described to me that you only have so much bandwidth. So there are only so many things you can really take on at a time. So if you have multiple disorders, it may be necessary to focus on some things that seem to be more treatable to reduce the overall symptom burden to the point where you can get a little more focus on the avoidant personality. I believe that motivational interviewing, such as they do with substance abuse, could be of value with avoidant personality disorder. Basically, I found that if you have a patient who is motivated to change, you have a fair chance. You have a patient who is not motivated to change, it's going to be really challenging. And the reason is that our treatments, be they medication or psychological, require effort in dealing with difficult emotions or side effects. So, motivational interviewing, which I'm sure most of you are familiar with, is going over the risks and benefits of their current situation, in this case, with the avoidant personality traits, and trying to get the patient to come to a conclusion that they might want to move off for some reason a bit from their current status. The fear of social contact is another obvious symptom. The avoidance, I mean, behavioral techniques with exposure and response prevention are extremely powerful. As you all know, they can be done with social fears, which is you do for social anxiety disorder. So these are a mainstay of treatment. Interestingly enough, there are organized private groups which are not clinically based, such as Toastmasters, which are essentially a social anxiety avoidant personality disorder treatment group, self-support treatment group. I've referred a few patients there. They seem to be helpful, and they lack the stigma of it, dealing with a mental disorder, which is sometimes important to patients. Now, again, I mentioned earlier, but it's worth reinforcing that you can get a powerful reinforcing effect by avoiding the feared situation. So, and avoidant personality disorders will do that. They'll avoid social contact. They'll feel relief. It's incredibly powerful. And somehow you got to break that cycle, which is may not be obvious. I mean, however you do it, it's basically the key cycle you've got to break. All right. Now, there are many ways, sub methods of going at this. Cognitive treatment is important. There are dysfunctional cognitions about the result of being in a social situation. I mean, talk to these patients and they're absolutely sure that they're going to make a minor error talking to people. They can be shunned. They'll have to move to a cabin in the woods. I mean, it's seems weird, but you know, they underneath it there are the fears. There's a need to restructure the perception of social interactions. I mean, often this is done by giving examples of other people. For instance, they feel like they're giving a talk and they stutter. That will ruin the entire talk and people will reject them. But then you ask, well, have you seen a talk where other people have had a minor glitch or a stutter? And they will say, yes, I have. And then you ask, what was your reaction? And they realize that they did not have that reaction. You may need to deal with both immediate thoughts and higher order beliefs. I mean, the immediate thoughts of the people, they may get rejected or do something that will be inadequate. Higher order beliefs are pretty much that they're basically defective. And so those have to, I mean, those may be worth working on if you can get to that. In addition to using experience such as exposure and response prevention for social situations, learning by observation and modeling can work. You have people who watch how other people perform socially or overcome problems is also a powerful method to treat. Now I get to something which is a little idiosyncratic, which I'll admit to at the beginning, because I mentioned what I call trauma-based behavior. Now, this is not like DSM 5R, whatever, TR, trauma with somebody pointing a gun at your head or falling 5 stories from a building. The way to explain this is that there have been studies done where people looked at a population and they gave something like the SCID to the group, and then they can look at people who met the DSM criteria for PTSD. But then they also could find another group that did not meet the severe stressor criteria, but they met everything else. So there's some group of people who kind of feel traumatized. They don't meet PTSD, but they feel traumatized by situations. And I think that may be some of our avoidant personality patients. So sometimes it's useful to think of it as sort of a trauma-related behavior, although not exactly PTSD, although not PTSD. Behaviorally, we need to teach them to deal with physical symptoms. That's education, exposure. Social exposure is very important, both individually and groups. I mean, groups is probably one of the most powerful methods, but the problem is it's hard to get people to get this group into them. I remember when I was doing research on a review article for the outcome of the effect of personality and outcome, I found one outlier. This was that patients with avoidant personality disorder in this particular study actually did better than other people rather than worse. So I took a closer look at it, and these were patients in a substance abuse program who were forced to be there. So by the process of being forced to be in the groups and interacting, they did a lot better. But usually it's very difficult to get these people in groups, but if you can, that's a big help. There is some evidence toward attentional bias, towards negative or ambiguous stimuli. This is not, I think, the major factor for avoidant personality disorder, but it may come into play with some patients. And there's some evidence that it can be helped with treatment or conditioning. Lack of social experience and social network. Well, here I've got to say that, again, this is not 100% for all patients. Most of what I'm saying is not 100% for all patients. But on average, those patients with avoidant personality disorder will have fewer social skills than the general population, but there is an overlap. So it's not like there's one group way over here and one group over here. At times, however, it may be a focus of treatment. Role playing is probably a good way to determine skill deficits. There are some standardized ways to do this if needed, although I'm sure you can actually do them without that in therapy. Again, there's evidence of effectiveness and depending on the specific needs, although not a primary treatment. Trying to develop pre-social support, of course, would be key. Then we deal with the issue of shame. Now, as I say, these patients feel shame for their behavior. And so how do you deal with this? Well, there are a couple ways to deal with this. One way I think of is kind of exposure, which is basically if you can get the patient to sit with the feelings of shame, their perception of them tends to change. I mean, I call that exposure. That's kind of like exposure to almost anything, but this would be like exposure to a painful emotion. Mindfulness is a good technique and often used in many different treatment situations to reduce anxiety and even social decision-making. And this can be done briefly. I remember seeing a talk by a psychologist who was assigned to work with residents at UCSF. Now, often when you think about mindfulness, you think about or you hear from some girl, well, you started at half hour twice a day and they work up to 4 hours a day. It seems like it's like an insurmountable amount of time. But actually, it can be done briefly. There can be brief check-ins to check your body state and what you're feeling. With the UCSF residents, they can do that briefly between patients, walking from one office to another. So there are techniques which don't take the entire day. Sometimes apps can be a useful adjunct. I mean, one that came to mind, for mindfulness, Headspace. The American Psychiatric Association has a website listing of apps, and I haven't checked it out, but I'm absolutely sure that the American Psychological Association would as well. I mean, they're very on top of things. So there's a limitation to apps, however. If you just say to somebody, here's an app, go to it, they tend to stop fairly quickly. Apps can be a useful adjunct as long as there's actually a therapist's involvement. So they can't be like standalone so far. But they can be a useful adjunct. And there's also the demoralization resulting in lack of motivation. Want to create a supportive treatment environment. And here, positive psychology may be of use. Just focusing on the positive aspects of social interaction, even if, even if they're relatively minor. It's a well-developed technique and therapy, as you all know, and it may be useful in overcoming demoralization. And I think, some of this is covered. I've listened to other talks in this series, so you can go back and some of the comments made in other treatment talks. The ADAA series also are helpful in that. But a possible useful technique, often with many of my patients, I will take a few minutes at the end for positive psychology. All right, so where are we? Avoidant personality disorder is a common disorder, which you will see as clinicians. It has high morbidity. The disorder has variations with treatment best tailored to specific symptoms. Our treatments can reduce pain and suffering for avoidant personality disorder. Thank you for your attention. I will now see what's on the question. Let's see. Oops.
Yes, thank you so much, Dr. Rich. I did send you questions that I've received during the webinar presentation. You should have that now.
And let me take a look. Okay, is avoidant personality disorder egosyntonic versus social anxiety disorder? Well, that's a very interesting question. Basically, the way I view it is that for many anxiety disorders, not just avoidant personality disorder, there is often a discomfort with it, which allows you to get into treatment. However, at times, there can be what I call a capitulation, where you just kind of give up. I mean, an example is with a different disorder, panic disorder, is as long as the person with panic disorder says, yeah, I have a problem, it's hard to go out, you have some chance of success. But as soon as they say, I have everything I need in my apartment, then you're kind of in trouble. Then when it does become egosyntonic, or they kind of capitulate. Now, we don't have any evidence that there's a strong dividing line between avoidant personality disorder and social anxiety disorder. I look at it as a sort of a dimensional personality disorder, although there are dissenting opinions in the literature. There's some people who argue fiercely that, you see, these things there's some subsymptoms that make it a separation. But I wouldn't put that as a way to separate the two disorders, whether they're egosyntonic or not. Okay, so the next question is someone who has difficulty with relationships, but high education and high income. Is that uncommon? I mean, it can happen. I mean, there are people who manage to find ways to be. I mean, in general, there's lower education, low income, but there are people who are somewhat avoidant who manage to do better. I think it's worth looking at whether there's avoidant traits. I would also give them the big 5-factor test I mentioned earlier, which gives you all the factors to see if there are other personality issues that are there that may be triggered by that test for you to look at. Okay, somebody says, I don't see how it's possible to meet DSM criteria for avoidant personality disorder and not also meet criteria for social anxiety disorder. Okay, and then, well, I would tend to agree with you, but there is a literature of people who find subtle differences. I mean, but in general, I would think that that's my opinion. I point out that's not the opinion of all the experts in this area. You go on, you say, in addition, most socially anxious persons do not suffer from an exaggerated fear, phobia, but also have core beliefs of social inadequacy. And you say, so therefore, wouldn't it be more accurate to view social anxiety disorder, avoidant personality disorder as a spectrum of a single disorder? Well, I do. I believe you're right on that. That's how I view it. That's what I published on that. But I'm one expert, and there are other experts, and some of them insist that they're separate disorders. I mean, so there is a difference opinion on that, although I do agree with you on that particular one. Okay, you mentioned if I talk about overall lack of motivation that impairs work, or motivation specific to relationships. I was focusing more on motivation specific to relationships, because if you have an avoidant personality disorder and they have a task which is non-social, that they can get motivated to do that. I was focusing mostly on specific relationships, or motivation to do therapy, because if you think about it, if you're a socially anxious, one of the worst things you can imagine, let's go into an intimate relationship with a person in a group to talk about my difficulties in relationship. It's very frightening to them. So I was talking about relationships. All right. He says, I had a question. In my clinic, treatment, mainly social anxiety, we ask patients not to take before their session. Most taper off altogether. All right. Well, I mean, that's an excellent question. I think that if you're successful in treating social anxiety, they should require less medication over time. My theory about medication for social anxiety symptoms is that you want to lower the symptoms down so that they can easily do therapy if that's necessary. So if you're climbing the wall of anxiety, it's hard to do this. So if you can cut off enough of that so that you can begin to do these, and then perhaps taper the medication as you gain skills, that would be an aid to these patients. That would be an aid to these patients in their treatment. So the other thing is that with treatment with medication, we're not so good that we can just kind of say, all right, we can hit it perfectly and it's all gone. Usually the best we can do is we can take the edge off, which will still leave plenty of symptoms for treatment, which then can be, as the medicine is removed slowly over time, as things improved, you might be able to more gradually treat these symptoms. Now, that being said, everybody has their own technique and in their own hands works well. What you're doing does work well, fine. On the other hand, if you have somebody whose anxiety is such that to a level it's difficult to work with, you might consider using medication to lower it to a level where they can function better in therapy. Okay, next question. You have a patient motivated to change but complains of chronic fatigue, which his primary doctor agrees. Not sure if it's true fatigue, the medication is on, or motivation. Well, let me first say that you're approaching this correctly. You got a question of fatigue. You want to have the patient examined by a physician to determine that you're not dealing with a physical issue, which is completely appropriate. Medications are something you should review for side effects, which they can cause that. I mean, absolutely. Now, so I think both of those are worth doing. I suppose once you've gone through that, you might want to check and see whether, what we're dealing with is depression, which might present as to fatigue or lack of motivation. If it's actually a chronic fatigue syndrome, that probably requires a medical specialist, if it's determined to be medical. So I've kind of been all over the map on that one, but I hope I addressed some of your questions. Yes, now somebody asked me to clarify what I said about PTSD. It sounds like some avoidant personality patients may meet many of the criteria, but not the severe stressors. And the answer to that is yes. There are many people out there who will meet the criteria for PTSD except the severe stressor. These don't count as PTSD, but they do sort of relate in a traumatized fashion. So yes, you did take that, you did get that essentially correct. And I don't think that's completely mainstream, but I think that it does happen. Okay, let's go on to the next question. Is there a relationship with high functioning autism and avoidant personality disorders? I believe they're separate disorders. I'm not an expert on autism. I think the similarity might be difficulty in forming relationships, but for very different reasons. But again, I won't get too much into that because I'm not an autism expert. So this seems to have covered our questions, unless there's something else.
Yes, no, you have indeed answered all questions that I have received. And again, I want to thank you so much, Dr. Rich, for taking the time to present this fascinating webinar. And I want to thank everybody who is participating, and to remind you all again that if you are interested in or have registered rather for CECMEs, I will be forwarding an email from webinars@adaa.org with all of the information you need in order to obtain those. So thank you all again. I hope to see you at a future ADA conference. And once more, many thanks to you, Dr. Rich.
My pleasure to be here. Thank you for having me.
Bye-bye, everyone.